3. Today we're going to be talking about arterial blood gas diagnosis. I have a little refresher on acid-base chemistry, but I'm going to try to highlight what you need to know from that little refresher. Are there any questions for me about yesterday's lecture?
I was going to ask about today's.
Oh, okay, we'll get to that. So before we get to today's topic, I have some questions for you, and I know we just had the lecture yesterday, but if you guys remember any of this, or if not, we'll walk through it. So, first question, what causes the extrinsic pathway to become activated? One person answer that. Okay. Tissue damage, yes. What else? Getting shot, yes.
Getting got.
Getting got. If you get shot, you got. Right? Don't get got. Right. So, for the extrinsic pathway, what factor gets activated? And how? 3, right? 3. And how or when is 3 activated? Yeah. Like, what causes 3 to become active? It's exposed to the blood, right? So 3 is in the endothelial lining of the vasculature, and once it gets exposed to the blood, it becomes activated. 12 from the intrinsic pathway is already floating around it. So 3 is not. Okay? Yes.
Are you like protecting us from words? Like you say 12 and 3, are there is there something that usually goes behind that?
The factors.
Like is it just 12?
Factor 12, yeah, it's Hagman factor
Okay.
is the name of it, and factor 3 is the tissue factor.
Okay.
So yeah, so I'm just not trying to preserve the amount of words I talk about. Probably are definitely tired of hearing me talking, especially after yesterday with all this, and I understand. So, what about the second question? What role does calcium play in the clotting cascade? Yes, calcium is involved in the common pathway activation, absolutely. Anything else?
Does it activate prothrombin? I forget.
That's a part of that complex that then goes on to activate prothrombin, and what else? So I might not have mentioned it, but it is on the slides. Calcium is a part of, it's not shown, but it's a part of a lot of different steps. Activated calcium was actually the factor that they thought was factor 6. So that's why 6 is no longer present, because they figured out that calcium was actually 6. Activated factor 6 was actually calcium, because since calcium works at multiple points throughout the pathway, they're like, well, I guess we don't need to have it listed twice, so they removed factor 6 from the cascade pathway.
Sir, are you familiar with the lethal diet?
No. What is that?
Like the hypocalcemia, acidosis, and
Hypothermia.
It used to be the lethal triad, and then they recently changed it to lethal diamond, and calcium is added, so.
Oh,
it
okay.
makes sense.
So is that when you're like treating trauma patients? All right. What about the third question? What is the purpose and products of methionine metabolism? Say again? Methylation, absolutely, yep. Yep, methylation. What can methionine become? Lots of things, yes. Absolutely, that's true. Cysteine, right, cysteine. Yes, I need to stop asking open-ended questions, because all of your answers are right. So yes, so you guys gave me the answer. So thymine is essential for protein synthesis, DNA methylation. SAM is the universal methylation group donor body, and that's S-adenosylmethionine, and then methionine can become cysteine through the transsulfuration pathway. What about the last question? What's the function of SREBVEBP?
Isn't that the one that regulates DNA expression within?
Absolutely. It regulates cholesterol levels through production of hydroxymethylglucoa reductase, which is the enzyme, rate limiting enzyme of the cholesterol synthesis pathway. All right? Any questions about these? Yes.
I just have a question about how the cofactor deficiencies don't affect the later compartments. So like in the cofactor 12, there's a deficiency in that, how does that not affect the rest of them?
That's a good question, and I don't know the answer to that, but I will look into that. That's the only one that doesn't affect clotting. The rest of them, if they're deficient, it will affect clotting. Now, for the activated PPT test that they do for the heparin treatment, they will see like some differences with people that don't have factor 12, but that's only on the test. In vivo, they don't have any blood clotting issues. So, but I will look into that.
Question here, sir.
Yes, sorry.
Sir, if the extrinsic pathway is activated, since you're getting like injury from the external, from the outside, and then you're causing injury to the internal, so would that automatically activate the intrinsic also?
Well, that's a good question, and one of your classmates asked that yesterday. And so what happens is when the extrinsic pathway is activated or the intrinsic, what happens is once factor 10 is activated, that somehow it doesn't the activation doesn't go backwards, but somehow that causes, and I don't know all the mechanisms, it causes like if factor 3, tissue factor 3 was activated, extrinsic pathway. Once factor 10 is activated, factor 12 will then be activated. And then basically it's trying to reinforce that fibrin clot that's eventually formed. So yes, to answer your question, yes, if one of the pathways are activated, then there's a chance that the other one will be activated. I'm not sure of the exact mechanism of how it works, but the goal is to try to reinforce that fibrin clot that's formed in order to stop leaking. Great question. Any other questions? Okay, now we're going to talk about a little bit about acid-base chemistry. There are a number of theories that define or regulate acid-base theories. The one that's most important is the Bronsted-Lowry theory, and that's the one that we're going to focus on. It is the foundational theory that relates to acid-base chemistry in our body. And that theory states that an acid donates a proton and a base accepts a proton. And so when we look in the body, that's the main one that we are looking at in terms of regulating acid-base disturbances that can occur. So we know that in order to have physiological homeostasis, that we need to maintain our body at the correct pH range, the correct carbon dioxide range, and the correct bicarbonate range. Carbon dioxide and bicarbonate are the major components as it relates to acid-base chemistry. So our body, we know that blood range that our blood needs to have, our blood pH range is 7.35 to 7.45. And this is regulated through bicarbonate, which is a weak base, and through carbon dioxide, which is the acidic component of this pathway. And so we've already talked about one of the acids. We talked about lactic acid, and in block 2, when when it came to glycolysis, and that plays a role in causing acid-base disturbances in our body if there's too much lactic acid. And bicarbonate is the weak base, and we're going to talk about how bicarbonate is formed in a few slides. But before we do, so the basis for acid-base chemistry is based on the dissociation of water, and basically when water is in solution, pure water, it will separate into a hydronium ion and hydroxide. This is a reversible reaction, and so the hydronium ion is the acidic component of this water dissociation, and the hydroxide is the basic component. So that said, water is acting as an acid or base in this scenario, and that makes it amphoteric. So when we look at this equation, we see that the water molecule that donates hydrogen is the acid, and the one that accepts the hydrogen is the base. So you have your conjugate acid-base pair. So this donates hydrogen, it's the acid, and this will accept that hydrogen, and that makes it a base. And same thing here. This will donate a hydrogen to this, and that will become the conjugate base of this. So when we look at the dissociation constant for water, what we know is that at 25 degrees Celsius, there's an equal amount of hydronium and hydroxide ions in the solution of water, and that has been determined to be 1 times 10 to the minus 7 molarity, and that gives us our Kw, which is the water dissociation constant. So Kw is equal to the hydronium concentration, which is the acid, and the hydroxide concentration, which is the base. So they're in equal concentrations, so the water dissociation constant becomes 1 times 10 to the minus 14. And so this scale, this number gives us our pH scale. pH scale goes from 0 to 14, 0 being the most acidic, 14 being the most basic, and 7 being where the solution is neutral. So, and here at the bottom gives you the pH versus the molarity calculation respective to that pH. So pH neutral is equal to 7. When it's less than 7, it's an acid. When it's more than 7, it's a base. So if we were to calculate the pH calculation is based on the concentration of hydronium ions in solutions. pH is a negative logarithm base 10 of the hydronium ions. So that equation is pH is equal to negative log of the hydronium ion concentration. So if we have a hydronium ion concentration at the bottom of 1 times 10 to the minus 2, the negative log of that number is 2. Any questions about that? Yes? Yeah, you will need a calculator in order to calculate. There's only a few, maybe 1 or 2 pH calculations. It's going to be easy, trust me. I promise you. Yeah, we'll get it right. So, any other questions? Did you have a question? Yes. No. All right. Yes.
Is this example of like the FH3O, is that kind of like consistent on
Where are you at?
the bottom part? Like the last where it says FH3O, yeah. Is
H3O?
that going to be consistent like in purposes of like when you always are calculating the pH?
What do you mean?
Does that change? Like if, cause it says if H3O, so that makes me think like it's not always that.
Yeah, so that's just the amount of hydronium ions in that particular solution. So this is just an example. The amount is gonna be, it's gonna be different numbers, and we're gonna get into an example where it's a different number, so good question. So this is just one example, probably the easiest to show you that in this instance, 1 times 10 to the minus 2, basically that pH is 2, and we know that's a strong acid. All right. So when we look at the pH scale, pH is 2, the hydronium ion concentration is 1 times 10 to the minus 2, pH is 4, hydronium ion concentration is 1 times 10 to the minus 4. Now, this is a 10-fold difference between each pH number. So if you have a pH of 4 versus a pH of 2, pH of 2 has 100 times more hydronium ions than pH 4, right? So if we look at this example, calculating the pH of aspirin, so here the hydronium ion concentration is different. So it's not, you know, one, it's this number that they've calculated. So what would be the pH of this aspirin? Well, let's walk through it. You can start with 3 for sure. So what you need to do, and this is where you guys, I recommend you check your calculators, whichever kind you use on your computer or your phone. Make sure you have the right settings because the instructions might be different. So what you would do is you would plug the hydronium ion concentration, this number, and take the negative log of that, and you should come up with 2.76.
Do you run that number?
Say again.
Do you run that number or that's just it?
This is it. Are you guys coming up with that number? Yes, no, maybe. Yes, you got it. Okay, if you guys aren't getting it, just figure out how to set up that equation in your calculator. There's also an easier way. I think it's easier to do it. Instead of typing in this whole number into the equation, just take the negative log of 1.7 and then subtract that number from 3. So if you do that, you should get this number. And let me know if that works for you guys. Thumbs up. Any questions about this?
You have to add it on negative. You subtract it, it's gonna go.
Sorry, yes. 3, subtract that number from 3. Yes. Because what happens is, when we take the negative log of 3, it becomes positive 3. So you subtract this number, which ends up being a negative number. The 1.7 becomes a negative number in this. All right? So has anyone ever drawn an arterial blood gas or done the test? Do you mind explaining how you do it?
Like you're talking about just drawing out of
Yes.
your artery?
Yeah.
You just feel for the artery down here and then you put the needle in it, and when you pull out like a certain amount, you put it on ice, and you give it to a really smart person and they tell you what the answer is.
Yep. So the reason why I asked, because I didn't realize, I'm not a clinician, I didn't realize that it was a different draw than you know the normal blood draw. Do you know why it's different?
It's in
Type of vessel.
It's a different.
Yep. So arterial blood gas is basically you that's drawn in the wrist or radial artery, And what we're looking at, there's three parameters: the pH, the partial arterial pressure of carbon dioxide, and the bicarbonate levels. This equation is very important. This is an equation for the basis of arterial blood gases and acid-base disturbances, and that is carbon dioxide plus water in the presence of carbonic anhydrase will produce carbonic acid. Now, depending on what's going on in your body, that carbonic acid will quickly dissociate to bicarbonate and a hydrogen ion. Okay? So you guys have already talked about renal and physiology, so I'm sure you know much more and remember much more than I do about this topic. But in terms of acid-base disturbances and arterial blood gas diagnosis, the bicarbonate buffering system is the system that's most important. Our body has a number of other systems that are used as well, but this buffering system is present in our blood, and it basically helps maintain the body at the pH that it needs to be, and it does this through the lungs and through the kidneys. So the lungs, we either inhale or exhale. We exhale carbon dioxide, and in the kidneys, we either remove or retain bicarbonate, and that is what helps us maintain our body's pH. So when it comes to diagnosing arterial blood gases, we're looking at two conditions: acidosis or alkalosis. Acidosis is when we have too much acid of varying types in our body. Alkalosis, too much bicarbonate. And so there's a respiratory and a metabolic component of each of those. And we're gonna go over examples of each in our case studies in a few slides. But what's happening is, for example, respiratory acidosis, that occurs when we hyperventilate or hypoventilate, or it can occur during overdose. And we're going to talk about different examples of metabolic acidosis. And so, as I've mentioned, the lungs and the kidneys are the key organs that help maintain the blood at the proper pH that it needs to be. And so, with that, this pH scale for arterial blood gases is very important. I recommend you guys know this information because you will need to know this information to set up your diagnosis of our case studies, and we're going to walk through all of this. But we already know pH 7 here, neutral. Our blood is slightly basic here with this range. The partial arterial pressure of carbon dioxide is 35 to 45, but it's reversed. And what that means is that, so more carbon dioxide is acidic, means that you're gonna, the scale is gonna be reversed in this case. So when you have less carbon dioxide, you are more alkaline and you have alkalosis. So that's why the scale is reversed. And then for bicarbonate, the scale is 22 to 26, and then it goes in the normal linear direction that we used to see. There are two ways that we calculate arterial blood gases. I'm just going to show one way, but then we're going to use another method. The Rome method is, how many of you, has anybody ever had to calculate arterial blood gases before? Any nurses? You have? Did you use one of these methods that we're going to talk about today?
It was something like Rome, it was several years ago.
Okay. So the Rome method is acronym Rome, respiratory opposite, metabolic equal. So when we think about our arterial blood gases, there's a respiratory component that deals with carbon dioxide. The metabolic component deals with bicarbonate. So what happens is our old respiratory opposite, so if we have respiratory alkalosis, that means we have loss of a lot of acid. So our carbon dioxide levels are low. When our carbon dioxide levels are low, that's gonna raise our pH. So what's happening is pH high, carbon dioxide is low, and vice versa. So for the Rome method, respiratory opposite, when there's a respiratory issue, the carbon dioxide and pH are going in the opposite direction. That's what it's saying. So metabolic equal, we know bicarbonate is the basic component. So if pH is low, that means bicarbonate levels will be low. When pH is high, bicarbonate levels will be high. Okay, so here's that normal range that I recommend you guys knowing for how to assess arterial blood gases. And also what we need to consider is whether or not our body is compensated for the changes in our blood gases. So when pH is normal, that indicates full compensation. When all three values are abnormal, outside of the normal range, that is partial compensation. And when carbon dioxide or bicarbonate are within the normal range and the other one is not, that is uncompensated. And we're gonna talk about examples of each of these. So this is the method that we're gonna use to calculate arterial blood gases. That's the tic-tac-toe method. And so what you do is you set up your tic-tac-toe table, and the columns are the rows pH, PaCO2 and bicarbonate, and then the columns acidosis, the normal range for all of these values, and alkalosis. And so setting this up, keep in mind that CO2 disturbances, that's the respiratory component, and bicarbonate disturbances, that represents the metabolic component. All right, so we're going to, and this is just a bigger table, but we're gonna go over the first example now. So when you're setting this up, make sure you have tic-tac-toe table and the compensatory table to help you guys determine what's going on with this patient. If I can have somebody read this vignette with your outside voice, please. Yes.
A 44-year-old widower with a history of chronic obstructive pulmonary disease was rushed to the emergency department with increasing shortness of breath, pyrexia, and a productive cough with yellow-green sputum. He has difficulty communicating because of his inability to complete a sentence. One of his sons, Thomas, says he has been ill for about 3 days. On examination, crackles and wheezes can be heard in the lower lobes. He has tachycardia and a bounding pulse. Measurement of his arterial blood gas shows pH of 7.3, PaCO2 of 68 millimeters of mercury, HCO3 of 28 millimolars per liter, and PaO2 of 60 millimeters of mercury. How would you interpret this?
Thank you very much, thank you. So, what I forgot to mention is, when we calculate the arterial blood gases, we start with the pH, then move to the PaCO2, then the bicarbonate. Then we look at what type of compensation is going on, if any. So there's a lot of things that are going on with this patient. They have COPD, so we know they have breathing issues, of course. That pyrexia is just they have an elevated temperature, and the productive cough indicates some type of respiratory infection. And so he's not able to complete a sentence because he's having trouble taking air in and out. So when we look at the arterial blood gas parameters, we see pH is equal to 7.3. So where would pH go on this tic-tac-toe? So pH would go here. Where would we put it? Right here? That makes sense? So it's below the normal range, all right? So far, that's representing some type of acidosis potentially, but let's keep going. What about carbon dioxide levels? So where would it go? To the left or right or middle? Left? Does that make sense? All right. So remember when we calculate or when we assess the arterial blood gases, we're looking for a metabolic component or a respiratory component. So we're seeing acidosis with the respiratory component. So it's looking like respiratory acidosis so far, but let's keep going. So what about bicarbonate? What level is that at? It's what? Alkalosis. So it's too high. So it's all the way to the right. Does that make sense to everybody? So it's looking like the patient is suffering from respiratory acidosis. So when you're determining the arterial blood gases with the tic-tac-toe method, pH and whatever component is associated with it will give you what type of condition it is. So this person is in fact suffering from respiratory acidosis. But now we need to see if there's any compensation occurring. So looking at the compensatory table, pH, is it normal? Nope. What about is PCO2 or bicarbonate, or is that normal? Are either of those normal? So all of them, all the values fall outside the normal range, right? So that means that this is respiratory acidosis that is partially compensated. Does that make sense? Any questions about that? So when calculating arterial blood gases, there will sometimes be more information than you need for the actual assessment based on this criteria here. Like they had the oxygen levels in there. That oxygen level is low, and of course that is to be expected with somebody with COPD because they're having trouble taking in oxygen and exhaling carbon dioxide. So just keep in mind when calculating this to focus on the parameters that are involved in the actual assessment, but you can use the other, if there's any other information given, that will be used to help you assess your patients when you guys are in practice.
I got a question, sir.
Yes.
So is there ever a time where like two of them are normal and one is abnormal?
We'll talk about that. Good question. Very good question. That's going to be later on. So next we'll move to this vignette. Please, another volunteer, would you read this?
I got you, sir.
Oh, thank you. Yes.
Jack, a 7-year-old, was rushed to the hospital due to vomiting and a decreased level of consciousness. The patient displays slow and deep breathing, and he is lethargic and irritable in response to stimulation. He appears to be dehydrated. His eyes are sunken and mucous membranes are dry. And he has 2-week history of polydipsia, polyuria, and weight loss. Measurement of arterial blood gas shows pH of 7, PaO2 is 90 millimeters of mercury, PaCO2 23 millimeters, and HCO3 is 12. Other results are sodium 126 and K plus 5 and chloride 95. What is your assessment?
Thank you very much. So, what is this patient suffering from? You guys already know. What disease does he have? Diabetes. Yes, diabetes. So you already know what this is going to be. So, but let's start with the pH. Where should the pH go? To the left, right? Its pH is 7. That's below the normal range. What about the PaCO2? Which way? Alkalosis, absolutely. And what about the bicarbonate? Where? Bicarbonate is 23. So where should it go?
Right.
Normal, thank you, yep.
The company's 12.
Oh, sorry, I was looking at the wrong number, my bad. Sorry. So, yes, it's low. My apologies. Bicarbonate is low. So when determining arterial blood gases, remember whatever follows pH, meaning respiratory or metabolic, is going to tell you what type of condition this person is suffering. So what are we thinking they're suffering based on this so far? Metabolic acidosis, right? Does that make sense to everybody? All right. Now we're going to see if any compensation is available. So, what do you guys think based on what we talked about? Say again.
Partially,
Why?
because they're breathing and compensating.
All of them are abnormal, right? All of the values are abnormal. Yes.
What was it again that decided between respiratory and metabolic? Is it just the way that they're presenting, or?
So it would be this is the respiratory component, and this is the like breathing, carbon dioxide, and the bicarbonate is the metabolic component. All right.
It might help some people to remember, so you can't really take your, like your HCO3, you can't really take that in the streets, but you can measure your CO2 with end tidal. So CO2 is coming from exhaling, so that's how I remember that it's respiratory. If that helps.
Thank you. Does that make sense, everybody? Is that clear? So when determining what's going on, one of these, either respiratory or metabolic components, has to align with the pH, whatever the pH is. So that's going to tell you what's happening, right? And you guys determine that it's partially compensated, so that's metabolic acidosis partially compensated. Any questions about that? Yes.
What is compensation?
It's like the body is trying to fix the problem. So the body is trying to work to correct the issues in this case. All right. Next one, yes. Can somebody read this one for me, please?
A 48-year-old female presents to the emergency department after she fell to the ground and hurt her left leg. She is noted to be tachycardic and tachypneic. She was given a narcotic analgesic to lessen her pain. Suddenly, she started complaining that she is still in pain and now experiencing muscle cramps, tingling, and paresthesia. Measurement of the arterial blood gas reveals a pH of 7.6, PA of O2 120, millimeters of mercury, carbon dioxide 31 millimeters mercury, and bicarbonate 25 mmol/liter. What does this mean?
Thank you very much. All right, so pH 7.6, where is that going? Alkalosis, correct. So this patient that she has tachycardia, that means the heart is beating fast, that paresthesia is tingling in her extremities, and that can happen in the condition that she's suffering from, and we'll talk about it. It has to do with calcium levels being disturbed. But what about the carbon dioxide? Where should that go? Is it low, high? Alkalosis. All right. So it's already looking like the patient is suffering from what? Respiratory alkalosis, correct. All right. So but let's look at the bicarbonate. Where's the bicarbonate? Right in the middle. Yep. So it's within that normal range. So based on all of this information, is there compensation occurring? No, and why not? Yep. Respiratory alkalosis, uncompensated. Any questions? This makes sense? All right, someone else please read this vignette if you don't mind. Oh,
Go right ahead.
Sally's grandmother has been suffering from persistent vomiting for 2 days. She appears to be lethargic and weak and has BIOCHEM. She is noted to have dry mucous membranes and her capillary refill takes greater than 4 seconds. She is diagnosed as having gastroenteritis and dehydration. Measurements of arterial blood gas shows pH of 7.5, PaO2 of 85 millimeters of mercury, PaCO2 of 40 millimeters of mercury, and bicarbonate of 34 millimoles per liter. What acid-base disorder is she?
thank you very much. So when we are vomiting, what are we losing? Acid, hydrochloric acid, right? So, and does anybody know what capillary refill is? Yeah, it's like when you pinch your skin, that basically assesses dehydration if your capillaries refill fast. So her refill is slower than it should be. So when we look at assessing the arterial blood gas, the pH is 7.5. Where should that go? Alkalosis, right? What about the carbon dioxide? Normal, right? That makes sense? And then the bicarbonate is alkalosis. So what are we saying for this patient? Say again?
Metabolic alkalosis.
Metabolic alkalosis. Does that make sense? And I already heard it, but is there compensation going on? Why no compensation? One is normal, one parameter is normal, and the other is not. All right. Any questions about this? All right. Right. One last vignette. Any volunteers?
I got it.
Thank you.
Baby Susan was rushed to the emergency department following her mother's complaint that the infant has been irritable, difficult to breastfeed, and has had diarrhea for the past 3 days. The infant's respiratory rate is elevated and the fontanelles are sunken. The emergency department physician orders the ABGs after assessing the ABCs. The results from the ABGs result show pH of 7.39, PaCO2 of 27 millimeters of mercury, and ACO3 of 19. What does this mean?
Thank you very much. So that diarrhea, what happens when we have diarrhea? What are we losing? Say again.
Chloride
I'm sorry, I can't hear you.
losing chloride and bicarbonate.
Chloride and bicarbonate, right? Did you have a question?
No, I was just kidding.
Oh, okay, yes, so we lose bicarb and chloride when we have diarrhea. But what about this baby is also, his respiratory rate is elevated, so what is he losing? CO2, so he's losing CO2 as well, so keep those in mind when going through this assessment. So, pH, where does the pH fall for this baby? Normal, 7.39, okay? What about the carbon dioxide levels? It is low, so that would indicate alkalosis. And then the bicarbonate level is what? Low, high? Low, all right. Low. So, what is this patient suffering? Complicated, absolutely complicated. So this is what would be called a mixed acid-base disturbance. You will not have anything like this on the exam, but in real life you will. So we're gonna talk about how we assess this, but this basically this baby is experiencing 2 different conditions. So if we were to see this, how we could get to one of the determinations is to look at the pH. So start back up at the top, the pH. So we know the pH range is 7.35 to 7.45. The middle range of that is 7.4. So what can we say about this pH? It's slightly low compared to, even though it's within range, it's slightly lower than the average range, all right? So we would shift that parameter to acidosis, and we would determine that this baby is experiencing metabolic acidosis. Now, is there compensation occurring?
No.
Yeah.
Or yes.
Yes.
Sure?
Yes.
Yeah, this one tricked me. I got. For real. No, seriously. So, I was like, but you're correct. It's yes. Because the pH is actually normal, right? That makes sense? So, this is, again, what's called a mixed acid-base disturbance. So the baby is experiencing metabolic acidosis and respiratory alkalosis. The alkalosis is due to the diarrhea, losing all that bicarbonate. And the respiratory acidosis is probably doing the baby's irritable, the baby's dehydrated, and also the baby's is like breathing very heavily, so losing a whole bunch of carbon dioxide. So in this case, the baby is experiencing both. And of course, in your practice, you might see somebody that does have a mixed acid-base disturbance, and so you would have to monitor them to know how to treat them. You have a question?
Yes, sir. So if it was 7.41, would it be osmosis?
Yep. Yeah, good question. Yeah, you would shift it the other direction. Yes.
Is any Q per liter and millimoles per liter be the same interchangeably for the bicarbonate ratio?
Yes. Yeah. Good question. They're not the same throughout the minutes. Any other questions? All right. I will see you guys tomorrow at 1 o'clock.
I'll say,